Our next speaker for the coffee break is Professor Anne McFarlane, who's Professor of Primary Healthcare Research in the Graduate Entry Medical School in the University of Limerick, and she's been a social scientist for over 20 years of experience, and I know Anne previously with my work with the National Consultative Committee on Racism that she did a lot of work with migrants and refugees and asylum seekers. So she's really got a very broad experience that she's going to be bringing here today. So I'm delighted to welcome Anne. Thank you very much.
Good morning. It's a real pleasure to be here, and thanks for the invitation. In this presentation, I'm going to talk through the rationale for public and patient involvement, and then I want to focus in on the spectrum of involvement for PPI, with an emphasis on the higher end of that spectrum and the notion of partnerships for health research. So really what I want to do is unpack what partnerships for health research have to offer for meaningful engagement. I want to talk about the issues of dialogue and the structures and spaces those dialogues, structures and spaces in which those dialogues may occur, and to look in particular at the tradition of participatory health research, which offers us a large resource for meaningful engagement. And I'd like to share an example with you of a completed project involving migrants in the development of a guideline for Irish general practice. So to look at the issue of the rationale for public and patient involvement, when I look at the literature, I see a number of different themes. And the first one really is maybe the oldest rationale for involvement and participation, which relates to the idea of social justice. My background is primary healthcare. The Alma Ata from the World Health Organization in 1978 said communities have a right to be involved in shaping health services and our understanding of health. The idea behind that really is to include people and to reduce health inequities. This notion of social justice and involvement and participation is seen for decades in community development and health promotion, for example. Then there's a theme about efficiency. This maybe is a little more recent. It's maybe attached to some of the consumerist ideology around this, which is, the health service is a public service. If we listen to our consumers of that service, we can find out the best way to spend the money so there's no wastage. There's also a notion of efficiency in relation to, well, what is it that we're researching? And there is evidence that researchers are sometimes funded to do projects that members of the public or patients would say isn't really relevant. So there is a notion that actually if you engage people in setting research priorities, we will use the money for research more efficiently. And then there's another theme which is more about impact, which is, look, let's face it, researchers have filled rooms with evidence of interventions or treatments or ideas that actually can impact on patient care and on community health. But getting that evidence into practice is a major challenge. There's a major translational gap there. And researchers who study that translational gap are very, very clear that if you involve the knowledge users in the research project from the beginning, then it is more likely that the findings will be disseminated and have some kind of impact. So the knowledge users may be patients, members of the public or community members, or people in the health service executive, people in the Department of Health. So that notion, if we could get together sooner, it will have a better impact at the end. Given that the rationale for PPI, as it's developing at quite a momentum in Ireland, that the rationale, if you like, come from a lot of different perspectives and a lot of different disciplines. So it's not surprising that it can be sometimes quite a confusing area to navigate in terms of terminology. Is it collaboration, consultation, involvement, engagement? What exactly are we talking about? Who are we talking about? Is it the notion of the public, the citizens, the community? Or is it always just when someone has become a patient or is a service user? And all of these terms are used interchangeably, which is often very problematic. And then there's the notion of representation. When we're meeting with a small group of patients or the public, how do we know what range of views they're representing? And this has been brought up this morning already, as is the notion of tokenism. It is worrying that there is a persistent concern about tokenism in the field of participation and involvement for many, many decades. It really is time for us to get this right. Against this backdrop of different rationales for PPI and a complex terrain in terms of the language that's used and the concepts that are important for PPI, I think it's really positive that the Irish Health Research Forum has brought stakeholders together, and we're at a point where we do have a working definition for PPI. It occurs when individuals meaningfully and actively collaborate in the governance, priority setting and conduct of research, as well as summarising, distributing, sharing and applying its resulting knowledge. I think it's also positive that in Ireland at the moment we have a set of guidance on what PPI activities look like. And there is a list, and there's also a view that, look, all of these approaches are valid. The level of PPI should be tailored to a particular project or initiative. And there's also agreement that there is this notion of a spectrum of involvement, that there are projects or initiatives that don't have a very significant amount of involvement. It may be more of an information exchange, if you like. But that at the higher end of the spectrum, there is a kind of involvement which actually is very involved and very engaged, where there is joint decision making and a sharing of control in the research process. And it's this level of involvement that I have a particular interest in. From a sociological perspective, I think it's interesting to look at where we are in Ireland in relation to PPI through a sociological lens. So, for example, these are all of the activities that we agree constitute PPI in Ireland. But if we take the example of PPI as co-applicants in a research project, well, I'd be asking, well, what does that mean? Do they get a phone call a week before the deadline for the grant and be asked, this seems to fit with the work you're doing in your community group or in your research charity group? Are you happy to be named in our grant? It would really help our submission. There's been no way there of a chance of a dialogue to shape what that research proposal is going to be about. The notion of people being members of a project advisory or steering group, and this is something that Katie has just talked about too. Again, very easy, isn't it, to imagine a scenario where someone accepts an invitation to be on a group, they get an agenda, they come to the meeting, they sit at the table, they leave, they get the minutes. You can tick the box, you can say, we have that representation on our steering group. Are we sure that there's actual equal involvement in decision making at that table? And what are we doing to make sure that that's happening? And then the notion of all approaches are valid and the level of PPI should be tailored to a particular project or initiative. And I totally understand why in Ireland we don't want to be overly prescriptive, as we're working in a very thoughtful way about developing PPI here. But you'd have to say, who's going to decide this? And on what basis? So I love Gary Larson. I always find his cartoons fantastic. This is kind of what we're not looking for here, where Noah has made a decision about how to fill the ark. And the poor old zebra's thinking, damn, alphabetically, it's not going to work so well for the zebra. This, if you like, is exactly what we're trying to avoid. So I want to talk for a minute about returning back to the literature and the traditions around social justice. And Paulo Freire is a Brazilian educator and philosopher who's always inspired me in his work. And in his work, he was particularly concerned with the differences between the oppressed and the oppressors. And he was passionate about the potential for education to transform things for both the oppressor and the oppressed. So education, he said, could either function as an instrument which is used to facilitate the integration of the younger generation into the logic of the present system and bring about conformity. People get education, but we're very controlling about what they're taught, so nothing actually changes at a social level. Or it becomes the practice of freedom, the means by which men and women deal critically and creatively with reality and discover how to participate in the transformation of their social world. Now that's really attractive. And I think it's interesting to connect some of these ideas to PPI in Ireland. I am not saying that health researchers are the oppressors of the public, of the community, just to be really clear. And I'm at the moment really just starting to think through these connections with Freire's work. But it is true that researchers, there is an asymmetry of power between researchers and the public and patient communities in terms of access to research funding, in terms of sort of legitimacy around doing research and so on. So there is something there around power and control that is worth unpacking. And what if we looked at this quote and played with it and inserted the notion of PPI into it rather than education? So we're looking at something like PPI either functions as an instrument which is used to facilitate the integration of the views of the public and patient community into the present research system in the academy. And that will bring about conformity, because we'll tick all the boxes, but we won't actually have change. What would happen if PPI actually became a practice based on opportunity? The means by which men and women from the community were sitting with men and women from the academy, also beside men and women from the HSE and the Department of Health, and they were really critically and creatively interrogating reality at the moment and looking together at ways to transform the knowledge we have about health and our health system. I think that is what we should be aiming for. How do we do it? Dialogue is the core mechanism, in my view, for meaningful engagement in PPI. And again, Paulo Freire can help us out here. He says, if the structure does not permit dialogue, then the structure must be changed. We need to create structures and spaces for dialogues in health research. Participatory health research is really a long-standing tradition which is very much linked to the rationales around social justice and the work of Freire. There's an international collaboration for participatory health research, which is a very vibrant network of people concerned with research of this kind. This is the definition of PHR, and you'll see that it resonates with some of the definitions around involvement, but there are a couple of key differences. Research is not done on people as passive subjects, providing data, but with them to provide relevant information for improving their lives. The entire research process is viewed as a partnership between the stakeholders, which may include members of the academy, professionals from healthcare, education, social welfare, civil society, policymakers, and others. So here, it is more radical, if you like, than some of the options around PPI, because it says actually a partnership from beginning to end is required if it is to constitute true participatory health research. Participatory health research also offers us a range of methodologies that can be used to frame dialogue, interactions, and discussions. Participatory learning and action research was developed in the Global South by Robert Chambers and developed by many others, including Mary O'Reilly de Bruin and Thomas de Bruin, who are based here in Ireland. Let's look at some of the features of PLA. It's a practical approach to research with diverse groups where asymmetries of power exist. So at its core, PLA is looking out for issues of power and asymmetry of power. And that's quite distinctive when you look at other research methodologies. It is designed to bring diverse stakeholders together to engage in a process of sharing and enhancing knowledge to identify solutions to shared problems and thereby achieving agreed goals. It's based on the premise that everybody at the table has different expertise, whether it's the lived experience of health and illness, whether it is a very sound grounding in research methods and analysis, whether it's a very sound knowledge of how the health service works. Everyone is at the table with their own expertise, and you will get further if those stakeholders collaborate, just as Mark was describing earlier this morning. PLA promotes reciprocity, mutual respect, cooperation and dialogue in research. Those are its values at the core of every encounter. And there are a range of techniques for generating and analysing data in a user-friendly way and with an emphasis on democratic decision-making through the process of generating and analysing data. So, participatory methodologies can be used to frame interactions in research spaces in a way that will look and feel very different to a lot of other methodologies. So what I'd like to do for the second half of the presentation is to talk you through a completed piece of research, which was a participatory health research project using PLA methods. The background, the health service issue, the societal challenge at the core of this project is that Ireland is increasingly diverse. There are over 200 languages spoken in Ireland at the moment, and on a daily basis, migrants and GPs are meeting without a shared language and culture. And we know that there are problems in those consultations in terms of GPs saying they're not in a position to deliver holistic care in the way that they've been trained to do. And migrant service users say it is very hard to have confidence in a prescription you're handed when you know you have not had the chance to explain your symptoms properly. We do not have an infrastructure of trained professional interpreters in Ireland, and certainly not implemented in the health service. So this research project, which was funded by the Health Research Board and the Health Service Executive, was based on a set of partnerships. We had community partners, 7 members of the migrant community who were concerned about this issue, colleagues in the Social Inclusion Office in the Health Service Executive, and then academic partners, so Mary O'Reilly de Bruin and Thomas de Bruin, whom I mentioned earlier, and myself were all working in NUI Galway at the time, and we were the academic partners. And Mary and Thomas also represented their organisation, the Centre for Participatory Strategies. And our work was to clarify with all of the stakeholders what is best practice for managing communication in cross-cultural consultations in general practice. We've published this work in 2 papers. The first paper is an account of the research process and sort of clarifying the content of the guideline. And the second paper concentrates more on the methodology and why and a process evaluation that we conducted to sort of document what difference the PLA method was making, if any, to the research process. And it did actually make a difference, and that's what the data in the paper describes. So in the next set of slides, I'm just summarising key issues from these papers, but if you are interested, they're there for reading in full. Okay, the first thing we had to think about in the project was sampling for participation. An issue like interpreting in primary care means that a lot of stakeholders are interested and involved. There's obviously the migrant service users, general practice staff, meaning the GPs, but also practice nurses, receptionists, health service executive people involved in service planning and policy making, and obviously the interpreting community. So we had to think widely of all of the potential stakeholders who would have an interest in this area. Because we believed that we all had expertise to bring to the work, we spent some time exchanging that expertise at the beginning. So for example, one of the things we did as academics was we summarised the primary care literature on cross-cultural communication and policy recommendations from around the world, and we shared it with the other partners, and we said, this is where the academics are with this. Here's a summary, what do you think? By the same token, the community and academic partners spent a particular amount of time at the beginning sharing stories with each other about our motivations for researching in this area. And we got to learn a lot about each other professionally, but also personally, in terms of why we were passionate about this area and why we were seeking solutions to this daily problem. Training is really important and essential to think about. When I started I've been doing PLA work for about 15 years, and I had a very sound background prior to that in qualitative health research. But it is a whole new skill set, actually, to conduct high-quality participatory field work. So I was delighted to get training from the Centre for Participatory Strategies, and in our project we organised that the 7 migrants who were involved in the project also got training in participatory learning and action research. So they became peer researchers in their own communities, thereby eliminating the language and cultural differences in the fieldwork, which of course we could never have done as the academic researchers. The training was obviously valuable in terms of skill development, but the other thing is it kept us together. It gave us a lot of time to work together, to become comfortable with each other, and to debate issues about the research. So through the process of the fieldwork, there was a lot of time also for everybody to have an input into what the protocol for fieldwork would look like. So there was a lot of co-design and sharing of decision making. And one of the peer researchers said, well, the relationship between the academic and peer researchers, they're not just work relationships, we're also personally connected. This makes the group very close. When you share an interest in something, you can discuss it, improve it, bring your ideas, It was all generated together. And it was really important for us to see this kind of data coming through in the process evaluation, because it was what we were hoping for, but as researchers you have to look for the empirical evidence behind that, obviously. At the end of the training, the migrants who had now become peer researchers felt this confidence that they could do the work, and they were ready to go and do field work in their own communities. So, for example, there was research with Portuguese-speaking, Polish-speaking, Urdu-speaking, Russian-speaking migrants, refugees, asylum seekers living in the Galway region. But the nature of the fieldwork that the peer researchers conducted with their communities was the very same as the fieldwork that us academics conducted with the interpreting community, members of the HSE and the general practice community. So we had high quality, comparable data from across all the participant groups. I mentioned a few moments ago that PLA looks and feels different to other research, and it does. And it's impossible in a short presentation like this to fully demonstrate that or share that with you. So here are just some photographs. I think the things I would point out is that it's generally PLA works well where data can be generated in a group setting. The work is highly interactive and has to be very, very carefully facilitated, so every member of the group has an opportunity to have their say and to debate the issues that are coming up through the group discussion. There's a heavy reliance on visual materials to record the essence of the discussion, and there's also a very, very interesting attention not only to what people are thinking and saying, but also the kind of emotions, if you like, that the issues can evoke. So the data can be generated, for example, with summary points on stickies, using photographs or using other kind of imagery, which everybody is co-creating together in real space and time, and can stand back at the end of a session and say, we created this. We all agree this is our co-generated knowledge. And importantly, through that process, there is a very, very, most of the techniques actually have an analytic element to them as well. So your participants have not only generated the data, but analysed them. And that is a really significant achievement in the area of participatory health research and PPI. And the peer researchers did comment on the fact that the migrants that they worked with really valued the PLA approach. Migrants in the fieldwork were showing an interest in it. In the beginning, when they saw the whole thing, when they saw the rooms laid out with all the flip charts and stickies and pictures and so on, they said, oh, this is very different. This is not questionnaires, it's a completely different experience. And the migrants as well, when we gathered data with them about their experience, they said, I feel honoured to have participated. It was excellent working in my mother tongue. I felt important, and I hope that my opinion will count while introducing the changes. We looked very deliberately and very hard for negative data from the migrants involved in this research, and there really was hardly anything. Once we had completed the field work, we set up a smaller working group with representation from all of the stakeholder groups to look at the results of the field work and to analyse the key findings, essentially what are we recommending as best practice. And this was a fabulous experience too, because there were several moments of insight, or what we called aha moments, where as a result of the dialogue and thrashing things out across the table, if you like, stakeholders' views were enhanced and changed by each other, by listening to each other. So, for example, one of the GPs was looking at the data saying, look, I see that members of the migrant community and members of the interpreting community are really against using family and friends and children as interpreters. And I know as a GP that's not ideal. But when I'm sitting there in the middle of a surgery, I have 10-minute slots, somebody comes in, their child is with them, it's just pragmatic. It makes sense to keep my surgery running. And that issue was debated out, and the migrants in the working group explained in detail what their wider community had said about this issue, the problems that it presents for adults who in fact will not go to a consultation depending on the nature of the condition if they think their child has to interpret, potential trauma for children, hearing details of medical issues that they just shouldn't be hearing. And through that process of dialogue, the GP said, yeah, pragmatics have to be put aside and we have to go for the ideal here. We have to make sure that in the guideline it's clear that children should not be used as interpreters. Equally, one of the migrants was listening to the GP perspective that, geez, it's very, very difficult to organise an interpreter to come along to a consultation, to get the 3 people in the room at the right time for 10 minutes, you know, really organisationally very, very problematic. So one of the migrants thought, well, what if your receptionist has the same language as the patient? You know, would that work as a solution? Again, it's not ideal, but would it be a possible solution? The GP said no. My goodness, we would never have a receptionist involved in a consultation. That would be a breach of confidentiality in the practice and against the principles of everything to do with confidentiality. We wouldn't bring our receptionist into any other consultation. The migrant said, I never thought of it like that. I didn't connect it with your principles of confidentiality in your work. Another shift in thinking, shift in understanding, another aha moment, and more clarity for the content of the guideline. Both of these got the thumbs down, ruled out of the guideline. So there was a very extended dialogue to analyse the findings from the fieldwork, to arrive at hopefully a democratic decision about the final content for the guideline. And we in the end had 100% consensus about what should be included in the guideline as best practice, the ideal strategies for supporting communication in cross-cultural consultations were to pertain to the use of formal interpreters and cultural mediators, people who had been trained and would be practising to a code of professionalism and ethics, and that they would be evaluated in practice, and the strategies that had low acceptability and which should not be used or not be promoted in any way are the use of family members or friends or other informal strategies like, you know, Google Translate or things like that. So I'm going to summarise. From a social justice perspective, PPI should be more than a list of activities or selected activities. Sustained partnerships between community, academic and health service partners are really valuable. The rich tradition of participatory health research can guide the development of those partnerships and guide the development of structures and spaces for equal dialogue and meaningful engagement. I think it's essential to evaluate PPI and PHR processes. The evidence behind it is the evidence for what's working, when it's working, why it's working is actually quite limited. And that's why I was really interested in the last presentation, Katie, you were talking about that importance of monitoring the work you're doing in the organisation and looking at its impact. And I think that is really crucial for us going forward. So I know that my own background is very much, all my experience in this area is with community organisations and NGOs around health service issues, and that's a little bit different from the focus of the medical research charities. But I really do hope that this overview is relevant and can inform some of the work that you're doing. Thank you very much.
Thanks, Anne. And we just had time for one question just before going for the coffee break at the back. Just if you could introduce yourself again, if that's okay. Yeah.
Thanks a million, Anna. Sarah Barry from Trinity Policy Management. Just a question. I mean, I'm really, really interested in this work, as you will know from previous conversations.
Yes.
And my own focus is on working with people working in HSC, etc. I'm interested in how you deal with time issues and actually getting people. I mean, this is a wonderful process that you're describing, but obviously, as we all know, real transformation is a slow change process, and it takes a lot of dialogue. And I'm wondering how, particularly from the perspective, well, in fact, of all of your participants, how you dealt with the issue of the time to engage, dialogue, field work, etc., the documentation, all of it.
Yeah, I mean, just to say, it was a 2-year project. So in its lifetime, it wasn't too long, if you like. I will say we were exceptionally busy for that 2 years in terms of trying to keep the quality hallmarks of engagement in place throughout the project. People are used to coming to focus groups, for example, which can take, you'd ask people to block off maybe up to 2 hours for a focus group. A PLA session is usually about 3 hours. Yeah. So there is an investment of time, and all I can say is, yes, some people do have an issue with it. Usually when people are involved in it, they see that time is worth it.
Yeah, buy-in from GPs, for example. sorry to
Yeah, no.
one group particularly.
Yeah, so they demanded huge.
That's my assumption coming out, that it might be a harder group.
I can say that there were particular things to think through about engaging with the GP community, absolutely. And as researchers, it called on us to be flexible. So, for example, it might have been that we met them in the evenings. Sometimes we met them over lunchtime. We did also have to truncate the nature of some of the interactive exercises for shorter engagements, and PLA is flexible like that. So in the project, some of the PLA encounters were 3 hours long, some of them might only have been 1 hour long, and we were able to adjust the methodology in that way. But I take your point, there is an issue about time, and you do need people to be available for the process.
Thanks very much.
Thank you.
Thanks, and I mean, I think it's just to say it's a fantastic presentation. The focus on social justice was really important, and I think it's a dimension that we really haven't considered that much. I think that needs to come back into the discussion. And I think it's a very nice example of a translational piece of research that is impacting on policy and practice, and particularly for very marginalised groups such as migrants and asylum seekers. It's so important that they get an adequate health service, and interpretive services and translational services are so important to that process. So we've a break now, and maybe just a round of applause again, just to acknowledge